Good morning, everyone. Thank you so much for joining us here for the next in our series on Aging Strong. Before we get started, I do just want to let you know about a couple of upcoming programs that are happening here at the library. Every Wednesday, we do have community yoga that takes place in our meeting room on the ground floor. You're welcome to bring your own mat, but we do have some mats that can be provided for you. And that runs from 9:30 to 10:30 every Wednesday. This week upcoming on Wednesday evening at 7 p.m., we're going to have a lecture called The Rise of a True Crime Podcast. This will be a discussion on starting a podcast. We have the hosts of the True Crime Podcast, and one, Diane, is a former court reporter, so she will be talking with her producer about some of the cases they've covered, as well as the background running of the podcast. And now I'd like to introduce our host for today, Debbie Lynn Toomey. She is the Injury Prevention Coordinator at Tufts Medical Center. Debbie, thank you so much for joining us today.
Thank you, Carrie. Thank you again to the Thomas Crane Public Library and QA-TV for allowing me to do this outreach work out in the community. And basically, Aging Strong Fall Prevention is a program that aims to educate, empower older adults so they can really live comfortable, healthy, independent lives. So today I have a guest speaker, Dr. Donna Bartlett, and she'll be talking about deprescribing and polypharmacy. And before she goes on, I just wanted to share with you, when I was working as a cardiology nurse at Tufts Medical Center many years ago, we used to have patients who would come in with suffering from a heart attack or maybe stroke or chest pain. And all of a sudden, these patients are given 5 new medications that they've never heard of before, but these medications are supposed to be taking care of their new condition. Well, these medications may have interactions, and sometimes the side effects are, really inconvenient or just really tough. And sometimes, medical experts out there just say, oh, well, it's just all the part of the whole process. So today, Dr. Donna Bartlett would talk about, how it's important for us to really be mindful and be well educated about our medications and to question which ones we should continue taking. So Dr. Donna Bartlett, welcome. Thank you so much.
Thank you. So excited to be here. Thanks for the invite. It's great to be here.
Definitely, definitely. Can you just tell us a little bit about yourself? You are
Sure.
a doctor, but are doctor of?
Pharmacy. And I'm also a board certified geriatric pharmacist. So I specialize on the geriatric side of things. And I really have worked with older adults for over 25 years now. I dispensed medicines for a number of years at a retail pharmacy, eventually went into a pharmacy outreach program, and now I'm an associate professor at Massachusetts College of Pharmacy and Health Sciences at the Worcester location, where I'm part of the pharmacy practice group, and I have a site for students at Health Alliance Hospital in Leominster, Massachusetts.
Wow, amazing. When I first heard you speak about polypharmacy and deprescribing, I couldn't stop nodding my head because it's just so important. We hear the word comorbidities. There are a lot of people, a lot of Americans have a lot of comorbidities. And that means just basically have very complex health conditions. And along with that comes medications to take care of these conditions. And sometimes these medications can be, I can tell you, a long list. And sometimes they interact with each other. So I'm really looking forward to your topic today. And if you want to start putting on the slides,
Sure.
presentation.
Happy to share my screen.
Awesome.
Let me do my slideshow.
And we have a nice group of people joining us today. So if you have any questions, please either type it in the chat or unmute yourself. So that way we could really gain as much as we can during our time together today.
Great. And Debbie, if I can ask, if you do see some chats, if you don't mind interrupting me, I'd be happy to respond. I just don't know if I'll be seeing those while I'm actually speaking. So thank you so much for that. So thank you so much for having me, and just welcome everybody who is tuning in today. And I'm just so happy to be speaking with you about staying wise and well, and really thinking about, is it age or is it medication? Because we find that we're taking medicines for a number of years, and there might come a time when medicines have done their job. They've really made us healthy and live to a long life. And it doesn't mean that anyone is giving up on you. It just means that your body's changed, and maybe the medicine is not as beneficial as it once was, and it's now causing more risk. So we're going to go through that process and try to see this evolution, if you will, of how medicines have really helped us, but how we are entering a whole new platform, if you will, of medicines maybe switching a little bit and causing more risk and harm than benefit. So this really is an overview today. There's a number of slides, but I'm not going to go deep into the slides at all. I just want to provide really thoughts for people to really be thinking about, because there's a lot to this and it's different for everybody. So we're going to just talk about polypharmacy, how it happens, and it does happen. And as you mentioned, Debbie, there's, we see people with really long lists of meds, but it doesn't have to be just the long list. It could be short lists of meds too, and there could be something inappropriate. We're going to think about how our bodies change, and we know they change. So we're going to be talking about that. I do have a 5-step process called the Medication Optimization Plan, or MOP. And we want to use this MOP to clean up our meds. This is what we're thinking about, right? We want to clean up our med list. So we want to optimize our medicines, and we do this through deprescribing. And deprescribing, we'll learn, is not just like stopping all meds. There's a process to it, and you're really optimizing your medicines. And then we want to think about the barriers. And you'd think like, wait, I'm on something I might not need anymore. Or you might be thinking like, oh, I've been on that for years. Why are you giving up on me and taking, want to take this away from me, kind of thing. So we're going to be thinking about that and thinking about, what are these barriers? Because you would think stopping a medicine would be an easy thing to do, but it really isn't. And we're going to talk a little bit about that at the end. So just a few facts that are listed here. And like I said, I'm not going to take a lot of time on all of these slides, but we know that a lot of people are hospitalized in the US every single day because of medicines. And if they weren't taking certain medicines, they might not be in the hospital. So we know it's because of adverse events. So these adverse drug events are more susceptible to older adults, because as we age, our bodies change, and we might become more sensitive to some medicines, or things have been added on over time, and now we might be having some issues with some interactions. So those are things to be thinking about. Did you know that about 40% of older people take 5 or more medications each day? And I'm not just talking about prescriptions. We have to think about the over-the-counters that people are taking, because that is medicine too. We have to be thinking about the supplements and the vitamins. And really the best way to be thinking about the problem of polypharmacy is the idea of deprescribing, and to be educated on that. So, I'm so happy everyone is here today to be educated on this, to be thinking about, oh, what's this polypharmacy and what's this deprescribing? So very briefly, polypharmacy comes from a lot of sources, and we know that there's lots of prescribers and lots of places we can get medicines. Add in a hospitalization and you might even have more added on. So these are issues with polypharmacy, and it's just additional meds and things not being necessarily reevaluated and taken away. And polypharmacy is not necessarily a number. We don't have to put a number to it. often what we'll see in research is 5 is the magic number. That's kind of the baseline, if you will, when you see various studies on polypharmacy. But polypharmacy could be any number of medicines. And really what we're thinking about are the unnecessary medications. So in what's really important here, and you talked about it too, Debbie, is that, you know, people have many multiple comorbidities, right? We have a lot of issues. Unfortunately, a lot of things might change as we age. And it doesn't mean that just because you're on 8 medicines, it could be appropriate for you, but it's the constant reevaluation that we need to do. So that 8 might be fine right now, but in another year or two, that 8 might not be appropriate, and some may become unnecessary at that point. So that's really the critical factor that we want to be thinking about. Polypharmacy can lead to a lot of things. And the one thing I want to talk to you about today on this slide is the prescribing cascade. You take something, you might have a side effect, and then you take something else. And you might not even realize that you're doing this. For example, you're taking medicines and now your eyes feel really dry. So then you reach for the artificial tears over the counter. You might be treating a side effect. Other things might be headaches. Other things might be a cough. So there are many things, constipation, diarrhea, all these things. You might actually be treating a side effect instead of, you know, an actual new problem. So, so when we go to the doctors, not only do we want to be talking about our problems, of course, because that's why we're there potentially, but you have to be thinking about, what have I been buying over the counter? Or do I have a supplement that I'm taking because, you know, I have leg cramps now, and I heard, you know, magnesium is going to help that. So these are all things to be thinking about. So why is polypharmacy a concern? Well, as we talked about, there's adverse drug reactions. We love to blame age on various complications we might have. And it really could be a medicine that's causing it. These are the side effects we've been talking about. And then there's also falls. Other things are hospitalizations and traffic accidents, but I really want to focus on the 3 that are highlighted here. So adverse drug reactions, there are many things that can be bump up, if you will, against medicines. It could be another medicine. So our drug-drug interactions. Sometimes you take a medicine for one thing and it could worsen something else. So you might be taking something to help you breathe, for example, and it could be causing you to be very dry and maybe causing you to have you know, if you've already had constipation, it could be worsening constipation issues. So those are like some drug disease things. Sometimes a medicine might increase our heart rate or increase our blood pressure, though we're being treated for blood pressure too. Drug food interactions. You see a lot of those labels on your medicine bottles. And so there's interactions we know between that. And then of course, drug alcohol. And there's many, many medicines that are affected by alcohol. So we want to be thinking about, you know, what we're doing, what we're taking, and how we're feeling. So these are the things that we love to blame on age, but it really could be medicine. And we're going to be going through these a little bit more, but we love to think like, oh, you know, I'm older, I'm going to fall. That's not true. Falls do not have to happen because we're older. You don't have to feel weak because you're older. You don't have to have sleeping problems or bladder issues because you're older. It could actually be medicine. So I know we talk a lot about medications and falls. I know that this is near and dear to you, Debbie, and what this whole aging strong is all about. But we really want to be thinking about all the factors that increase the risk of falls. And if you think about a block of towers, there could be all sorts of things that could be increasing our risk of falls. And typically falls are multifactorial. So it's not just our environment or the scatter rug. It could be a few medicines and our little pet that's scrambling by us. And maybe our vision isn't quite so good. We're not hearing the dogs, you know, come into the room that we're in. So those are all things that are adding to this tower. If you think about each medicine that might have an increased risk of falls, you keep adding on risks of falls, and pretty much sooner or later, that tower is going to tumble. And it's just because of all those risk factors. So if we can look at medicines and take away some of those risks, then we're doing a great job at helping to prevent falls, because we know falls are preventative. This is just some information that I have from Massachusetts, that in 2017, you can see the increased risk of falls that people have had as we increase in age. So we do know that as we age, in number of falls do increase, but we can prevent this too. When we're looking at geriatrics, and maybe think about those years span comparable to pediatrics. So in pediatrics, you certainly would not give a newborn or 1-year-old the same thing that you would an 18-year-old, but they're all considered pediatrics. In our adults, we have the rest of our span, right? So, and then we get into our older adult ages of 65 plus. So when you think about this, when you're 65, should you really be treated the same when you're 95? We don't do it when you're 1 to 18. So we really need to be looking at our medicines as we go through our older years of aging. It just makes sense. Our bodies are going to change. Our body's absorption changes. Our body's distribution of drugs changes. The metabolism of our medicines that we take changes, and also elimination of our medicines that we take also changes. So this is why not only from our 1 year to 18 years, but also 65 to 95, we see those changes happening. So who's responsible for all of this? We all are. Patients, providers, our healthcare system. We all are responsible for thinking about how we are going through our life and being treated. Are you a patient going to a doctor and saying, I really want something for this issue? How would you be about if a doctor says to you, you might feel better if you don't take a medicine anymore? Would that be shocking to you? And it probably is. But deprescribing is the same, if you will, as prescribing. It's a process. You can take something away and feel better instead of adding something more to try to feel better. So this is what we need to be looking at. So what is deprescribing? Deprescribing is the process overseen by a healthcare provider or team of healthcare providers of stopping a medication, decreasing a medication, or changing a medication to a safer alternative. So 3 things can happen. That's all under this umbrella of deprescribing. And this is why we talk about it being optimizing your medication use. So we really want to be thinking about deprescribing as a way to optimize. So this is our medication optimization plan, and I call it the Med Strong because we want our meds to keep us strong and keep us healthy and not make us feel weak and tired and fatigued, right? We want to be strong, so and be able to function. So we'll go through this process, but basically you're going to list all of your meds, but you're going to think about them a little bit differently. And you're going to be thinking about, does this problem still exist? And do I really think I still need this medication? And if you flag that, that's something you want to talk to your doctor about. So then we have questions that we need to ask, right? We have to have our conversation. I call it the do conversation, the deprescribe to optimize conversation. You need the do conversation. So, and then with your healthcare providers, and you can start with your pharmacist and start talking about your medicines and then come up with a list of questions to then bring to your physician's office. But, should you decide to deprescribe, then you need a plan. And we're going to talk about this plan and how we're really flipping the script. You're really taking a medicine and you're flipping it. You're doing something different with it. And hopefully you're tapering it, maybe changing it or stopping it if that's appropriate. But as with just like we're taking medicine, we still need to monitor, document, and follow up, just like we would if we were starting a medicine. So this is the first step that we want to be thinking about, Med Strong, and basically what are the medications, and like I said, does a problem exist? The big thing here is to really be thinking about sorry about that, is this yellow highlighted area. And, am I taking something that I'm trying to cure, if you will, or take care of? What over the counters? What's something new I started to take since I've last seen this doctor or, been to the pharmacy? And am I really treating a side effect instead? So this is just an example of it being filled out. And if you're not sure, that's your red flag. That's something you want to be talking to your doctors about. So just to run through a few quick studies, people do want to limit their medicines. 90% of people are willing to try, but once you start talking about the medicines, then that changes. And if you're talking about like blood pressure or statins or things like that, you tend to have, yeah, sure, I'd stop that. But if you're stopping about some, medicines for sleep or anxiety, that's when people start putting up their barriers and saying, no, I need that medicine. I need to sleep. But they could be affecting you. They could be causing you other side effects. This is a really great graphic that's been studied and used to help taper doses. So it's a nice way for people to say, okay, I'm in this week of deprescribing and I would like to, reduce my dose. And this was an example provided with some medicines called benzodiazepines that help with sleep and anxiety issues. So it was a way to have people visualize how they're going to get off of the medicine. And it does take time. We know this is not a fast, quick thing. The CDC has a program called Stopping Elderly Accidents, Deaths, and Injury called STEADY. And they talk about medications linked to falls. And if you see here, there's a whole bunch of things that they look at: anticonvulsants, benzodiazepines, antidepressants, opioids. So things that we're looking at that might increase the risk of falls. And that's what I was talking about, those blocks. You keep adding them on and you might eventually fall. So we want to reduce these as much as we possibly can. Falls are caused by a number of things like we talked about. And so now we're going to be thinking about this though. Falls can be caused by all this, but medicines can cause everything that's going on in this list. And we're going to just take a quick peek at some of the types of medicines that can do some of these things. So for example, fainting. What are some of the medicines that can cause us to faint? And it could be a diuretic, nitroglycerin. So these are just some things, and not to scare you, but just to know that it could be a medicine that might make you feel like you might faint. Gait and movement disparities. We know like muscle relaxants, it's not just that one tight muscle, it's all the muscles that relax. So that might cause you not to walk very well while you're taking that medicine. Vision and hearing can be affected by various medicines, either causing dry eyes or blurred vision. Sometimes medicines can cause ringing in our ears. So those are things that might affect us. Confusion. There's a lot of different types of medicines that might increase your risk of being confused. So we love to think like, oh, I must be being forgetful or confused because of my age. It could be a medicine that could be doing that. Dizziness and lightheadedness, there are so many. We often think of like blood pressure medicines, but there are so many medicines that can cause this. So we do want to be careful about the medicines we're taking. And if you are dizzy or lightheaded, or if you have to get up slowly, that's something to report to your doctor and even to your pharmacist that, you know what, I'm not feeling as steady. I'm feeling kind of dizzy and lightheaded. And that is important too. And then we have medicines that are just high risk. And these medicines, diabetes medicines, warfarin, levothyroxine, and digoxin, the reason why they're in the quote unquote high risk is that their dosing is very narrow. So one little change can be a big change for an individual. So we want to make certain that if you are taking these medicines, that it is the right dose, that you're getting the right evaluations on these medicines so that you're not increasing your risk of falls or increasing your risk of hospitalization due to maybe a high or low blood glucose or bleed, or levothyroxine, if you're taking too much, might cause heart palpitations. And digoxin can also increase the risk of falls and cause some cardiovascular changes as well. So these are some great conversation starters that we can be thinking about. And, just, is this medicine still working for me? Do I still need to take it? Could it increase my risk of falling? Those are things we want to be asking our doctors. And there's a whole number of these that can be looked at. So now thinking about where can deprescribing happen, right? So who can you be speaking with? And it's not just in the primary care, it's everywhere. You can talk about at the pharmacy, your primary care. If you're hospitalized, did a medicine bring me here? In the hospital, did it cause me to be here? Short-term rehab, long-term care, all these areas can deprescribe. These are some of the things that we need to be thinking about if there's are we tapering or not? And I just put it in here that there are lists available for healthcare providers to know the higher risk meds that might increase the risk of falls and that might need to be discontinued. So as we said before, we work a lot of years and then we finally retire. Well, your medicines might have worked a lot of years for you, and that some might need to be retired because they've done their job, and we don't want them to, not do their job and cause more harm. This is the part, the last step, and this is just about flipping that script. So, what does this mean? Well, you're going to take a medicine, you're going to write it down because you want to make certain that you're talking about the same medicine, that, that you and your doctor are on the same page, that this is the medicine that we're going to do something with. We're going to change it, we're going to reduce it, or we're going to stop it. And then if it needs to be tapered, how do you do that? And then there's always that monitoring side, right? Does your doctor want you to check your blood pressure at home? Do you have to check your heart rate? Maybe, are you sleeping okay still? Those are things that you might need to document over time, or maybe you have to go and have a lab checked in a month or something just to see if it's okay that you've stopped this medicine, just like if you had started a medicine. And then the big question is, how do you feel? And if it's no different, that might be fine too. It might mean you really don't need the medicine anymore. Better is great, of course. We love to feel better, but not so good. We might need to reevaluate. So, and just briefly, I want to talk a little bit about the benefits and barriers to deprescribing. So we know that there's so many wonderful things with deprescribing: fewer falls, improved cognition, people's quality of life is better. If you're not taking something, you're not going to have adverse reactions to it. You're going to have less drug interactions, and people tend to be pretty happy to be taking less. So really great benefits of deprescribing. What are some of the barriers? Oh my gosh, if I stop taking this, then what? And sometimes if that's the case, just reduce it slowly. It doesn't mean you can't revisit. It doesn't mean you can't restart. But it's just like starting a med. You don't know how you're going to react to that either. So if we can reduce, it's really a great thing. Prescribers also have their barriers too, because they like to do things that have a lot of evidence. And unfortunately, a lot of medicines and when they're introduced to the market, we know exactly how to take them and how to give them. But in those monographs, there's not necessarily information on how to stop or reduce medicines. So, there's not always great information on stopping meds, but there is a time when, if you're having more side effects, that we really want to be thinking about reducing medicines. And sometimes it's just easier to continue, right? The status quo. How many times have you heard, oh, everything looks great, keep doing what you're doing, but maybe you need to be preventative, because we don't want to wait for the fall. We don't want to wait for the traffic accident. We don't want to wait for the hospitalization before we start reducing. Let's plan ahead. Let's do things as we go so that you're not getting into those issues. So we need to rethink this. We just need to rethink some of this unnecessary medicines, even though they were necessary at one point, might not be necessary now. And we need to be preventative in continuing our treatment. Is this something that we should continue on? So we want to deprescribe to optimize. Are you in? Are you thinking about this? Do you know someone who's just, you're worried about, you think they're taking too many meds? Maybe they'll feel better if not. Help them, help yourselves, help those you're caring for, and we can deprescribe to optimize together. So I do have a book coming out called Med Strong, Shed Your Meds for a Better, Healthier You, and it should be coming out in this summer. So I do hope that all of this information is in there, and it'll be written, but it'll hopefully be a help to all of you. And I just want to say thank you so much for this time. We're going to open it up, but if you do want to learn more, I do have a website, donnabartlett.com, where it's all about deprescribing and being wise and well. So please join me on my website if you would like more information. And I'm going to stop sharing now.
All right. I feel like I need to take a nice deep breath because you covered so much.
I know it's a lot. It's probably too much, but
No,
hopefully it spoke to somebody.
it was perfect. And I invite everybody, if you have any questions, please unmute yourself or type it in the chat. But, you know, as you're talking, it just reminds me of when I was taking care of patients years ago. And there's just so many different, you know, there's so many different problems or obstacles that arises when the patient goes to the hospital because of either an emergency or, you know, an event. Mm-hmm. And typically they go home on new medications. Mm-hmm. And sometimes their current medications get changed and they're put on new medication. So it gets really confusing. And as a nurse, we're always supposed to discharge the patient, do med teaching, and, you know, making sure that the patient understands the medication. But your approach is, you know, years down the line. What happens when the condition is stable? And what happens when the patient is older and maybe some of their organs may not be functioning as well?
Right.
Maybe they've lost weight and their height is short, or their BMI has changed. They're still on the same medication. So these can really put people at risk for different things, like faults.
Right.
So, you know, I kept taking notes. I love how you talked about polypharmacy and, you know, can you speak a little bit more about patients? Sometimes patients mail away for their medications, and their usual pharmacy or pharmacist doesn't know that they're mailing away for a medication, and how some medications can actually counteract each other, cancel each other out. I did an Aging Strong program in person in the Kennedy Center in Quincy, and I was talking about polypharmacy and how I just shared that, you know, it's good for your doctor to know where you're getting your medications from. The pharmacist may not be talking if you go to a different pharmacy. And so that one participant said, remember that, and shared it with her friend. And her friend was saying, oh my gosh, I mail away for one medication, but my pharmacy doesn't know that I'm mailing away for it. And when when that friend told the pharmacist that they were mailing away for a medication, the pharmacist said, you know what? The medication they're mailing away for is actually canceling the effect of one of your important drugs.
So with that, like there's definitely some disconnect. If someone is using the same insurance for their medicines, it will still go through a cycle, if you will, and as a pharmacist, you might get back a message like this person is taking this. However, we know that not everybody uses their insurance for everything either. So if you're getting, say, for example, a low cost generic at that pharmacy's low cost price, and they're not putting it through the insurance because it's less expensive for the person just to buy it outright, then that medicine is not going up against the medicines that are being filled, if you will, at other pharmacies that are, you know, on their insurance. So there's definitely disconnects there for certain. The other thing too is that many pharmacies, they don't know what you have in your shelf, right? They don't know your over-the-counters. They don't know your supplements, and those get into trouble too. So and people think like, oh, it's fine, it's over the counter, but there's a lot of issues with over the counters. And what I like to tell people is there's a reason why there's all this writing on those labels. And even though you might not be able to see it, you need to grab a magnifying glass or something, because you need to see what the warnings are. Like, what are those issues? If you're taking this, you know, you shouldn't take this. Or if you have this particular condition, you should not be taking this. And there are reasons for that. Those are the drug-drug interactions, the drug-disease interactions that I had mentioned.
Yeah, definitely. And I loved how you talked about the adverse drug reaction. Can you speak a little bit more about the difference between side effect and that? Because sometimes people get them confused, or they think they're the same.
So, I mean, there's varying types, and really a side effect is, you know, the medicine is there's a lot of side effects to everything, and people will read like whatever medicine that they're about, you know, that they're getting from the pharmacy, and they're like, I'm not going to take this. But how many people read the side effects of something over the counter too? They can be just as scary, and they often are, but people just think it's, you know, over the counter. So side effects are listed as, you know, various issues. So, but an adverse drug reaction, it is similar to a side effect too, in that, yes, side effects can be under that umbrella, but adverse drug reactions can run throughout all of these various side effects, but cause such an issue that you end up needing either a new medicine to regulate, that's that prescribing cascade, or maybe you land in the hospital because of something. You know, an adverse drug reaction is really this this level, if you will, of really having an issue and really having it need to be addressed. So so people, you know, might have dry eyes or something, and they'll deal with it. But people might have a fall, they might have confusion, delirium, and that is something that needs much more attention.
Mm, mm, yeah. You know, as when you were doing a presentation, I kept hearing how important it is for patients, for people to be self-aware and to be their own self-advocate, because you get the white coat syndrome. You go in, you see the doctor's supposed to know, how to take care of you, and they do, and they give you the medication because that's what you're hoping for, so that way the symptoms gets alleviated. Yay, everything's good. But at the same time, it behooves the person taking the medication, to constantly be monitoring how their body is reacting, because it's your slide had a nice, beautiful picture of the trio, the patient, the prescriber, and the healthcare system. We as older adults can't forget that we are part of that team, and we're the most important part of that team, because we are the ones who know our body the most, right? So I really appreciated that slide, because you're putting the responsibility back on the consumer.
I think there's a shift too, because, I know with, my parents and my grandparents that there's been this, well, I take this because I'm told to, kind of thing. Like there has been some of that throughout the years. And now we're seeing this shift of people saying, wait, time out. Like I need to know this for me, kind of thing. And I think people are more willing to learn, but there's also that, wait a minute though, why am I still taking something that I shouldn't be taking, kind of thing? Or why is there this shift? And I think that it's important that people do not think that deprescribing is one conversation, that it's one check-in, that it's, you asked once on this medicine and you were told you need to continue it. And that might be true, but it really is a process. Just like you go for, a yearly physical, you really need your meds checked too. And they need to be checked by someone who is willing to look at all of them. Your pharmacist, and I'm sorry, I'm putting a plug in for your pharmacist, but your pharmacist is someone who is going to be looking at all of your medicines. And I don't mean to say that others aren't looking at all of your medicines, but your specialists are looking at the drugs that they specialize in and the ones that they are providing. And one of the barriers that we know is when prescribers don't want to touch other prescribers' medicines. So if you're seeing a cardiologist and they have you on certain things, your PCP, your primary care physician, might not touch those because the cardiologist is taking care of that. However, someone else, a gastrointestinal specialist, might actually be prescribing something that is an issue, right? And so who's going to know that kind of thing, and who is looking at all of your meds, all of your supplements, all of your over-the-counters? And it's true, you really have to use the tools that are available, unfortunately. Like, you can't assume that all of your meds are being checked. Just because you're at your doctor's office and they're going through the list of what you're taking, it doesn't mean they're doing an interaction check. It doesn't mean they're saying, how are you feeling? It doesn't mean that they're thinking deprescribing at that point. You're giving a list of your medicines and they're checking to make certain that it matches their list. Medication therapy management and deprescribing is a process. It takes time, and that is, again, another barrier to it, unfortunately. So you do need to be your own advocate and be thinking about, how would you know if you're having a side effect to something? You might not know you're having a side effect to something, but you can say, you know what, I had to start taking this, or I'm really feeling different, or I'm not steady anymore, or whatever it might be, and be honest about that. And think about what would make you feel better? Like, would you feel better if you were less dizzy? Would you feel better if you were stronger? Would you feel better if you were sleeping better? And so what medicines might be causing those issues?
Mhm.
It's a different way to think about it.
Definitely. When I used to take care of patients years back, I used to love doing the rounds and team rounds, because there would be the nurse, myself, the doctor, the medical students, the pharmacist, the social worker. And I love to hear different healthcare professionals' perspective, because that's how I was able to really pull it together for my patient. Because sometimes, the patient may be just looking at the whole team, feeling maybe intimidated, or maybe not be able to hear the conversation, maybe because they have poor hearing, or maybe they don't have a good command of the English language. So, it falls on the nurse to be able to translate everything, and to make sure that the patient knows what everybody is there for, which is for their best interest. So out in the community, it's different though. It's so different. And it's really important, again, for the patient, the consumer, to be self-aware of their body, and for an advocate, because it's, because of COVID, and I'm sure they were, pharmacists, I use a local pharmacy, and they have been so bombarded with patients, because now they're assuming roles that they didn't have to do before. And the lines are long to pick up medications, and you have to be 6 feet apart. And the technicians are busy, and they have only time to make sure you're the right person, identifying, all these different things, date of birth, whatever, you have the right medication, here's the next, then the person, the next. It's hard to find the time to have a consultation with a pharmacist.
Right.
Is there such a thing in the community?
Mm-hmm.
Or is that something you have to request when you see your primary care doctor?
Mm-hmm.
Um,
So different avenues for this. And you could request a consultation with the pharmacist. They might make an appointment with you. Whether or not so there are various types of consultations, let's put it that way. So if you have a question on something, of course, your pharmacist is going to be there and answer it for you. A full medication therapy management consultation is something that some insurances cover. And when we're talking about Medicare Part D, they do have to cover medication therapy management, but they have parameters around it. And you need to be on so many medicines. Typically, 8 is a number that a lot of insurances pick. You have to have certain disease states out of a menu of disease states. If you're outside of that, you might not qualify for medication therapy management. So, you tend to have 3 comorbidities, like we spoke about, 3 conditions, and they have to match their menu of conditions. And the other thing is that your meds have to be expensive. They have to hit a certain dollar volume in order for the insurance to cover it. So that might mean that someone who fits the number of drugs and the health criteria, but they're on all generics, then they don't need MTM. That's not really true. They still need medication therapy management because, as we know, any medicine, if you look at all those lists of medicines, might become inappropriate or unnecessary for you. So there are some medication therapy management that you are offered if you have Medicare Part D, but you might not be offered that if you don't meet those 3 criteria. Some doctors' offices, ACOs, or like various team approach primary care groups, they might offer pharmacist consultations, but it's through your doctor's office. So you could see if your doctor's office does have that available to them. They're not super common, unfortunately. And the reason for that is because because pharmacists aren't able to bill for this, and it has to be billed under the medical group. So they have to hire a pharmacist in order to do that. So it's a little bit odd the way that works. And then otherwise, you could be trying to get just somebody to help you out, a pharmacist to help you out. The other way that you could is to pay out of pocket. And some people do consulting on their own, and it's a pay out of your own pocket type of option. And in Massachusetts, we are lucky that we do have the MCPHS, the Massachusetts College of Pharmacy and Health Sciences Pharmacy Outreach Program. So all you have to do is be a Massachusetts resident, and you can give them a call, and they are available to do insurance reviews for you, affordability reviews, and also drug reviews for you. And that is a service that is provided through grants through the state and other grants that they're able to provide that.
Can you repeat that information again? Who should people
Sure.
get in touch with?
It's MCPHS, Pharmacy Outreach Program. Hold on for 8633. Okay, and I have the number. I just had to think about it because I used to be there. I was there for 11 years. And it's still ongoing. I just changed my role at the university so that I could do more faculty work and have this other site at a local hospital. But the number is 866-633-1617. So 866-633-1617. Another something that people can do, so say, for example, you have family and friends that are not available, and that are not part of Massachusetts. There is online a national organization, the American Society of Consultant Pharmacists, and they have helpwithmymeds.com. I believe it's .com, Help with My Meds. And in that, you can actually click on your state, and pharmacists in that area who are board certified geriatric pharmacists like me, they are populated in there so that you can talk to a pharmacist in your state.
Wow, that's great. That's great. Again, I'm taking a lot of notes.
Yes.
If anybody has any questions, please unmute yourself, because we'd love to hear your questions. So, so I am a daughter of aging parents, and I can't wait to take my parents for their next visit. You know, just through the lens of a daughter and also a nurse and somebody who has been really passionate about the aging process and, you know, prevention and really empowerment of the aging population. It's just it's a beautiful process, but there's just so many moving balls, and it's really important for us to get to know what is available for us. So can you share with us, we have, you know, a few minutes left, can you share with us where you see deprescribing happening in the future? What would be, what's your vision for that? What's your goal?
What a great question. Thank you for that. So again, like a couple of things I would love to highlight about deprescribing is, you know, not to do this on your own. Like, you need the conversation. It's a process. And like I said before, it's not just one time. And even if you have your own roadblocks, like you might talk to a doctor or a prescriber, anyone who's prescribing something for you, and you might say, do I really need this anymore? Of course you do. Like, and you're kind of fluffed off. I've helped families with their older adult parents, trying to help them navigate and ask questions, and they've been fluffed off by people. So it doesn't always go smoothly, and I don't want people to be discouraged. It's a different conversation. It is, like you're saying, it needs to evolve. So where do I see deprescribing going? I see deprescribing headed to every single encounter we have in the healthcare system. So yes, pie in the sky, but this is key in that if, like I said, you go to be seen, you're not feeling well, etc., you're expecting something. You're expecting a prescription of some sort, whether it be go see this physical therapist or start taking this, or, you know, take this over the counter, something. You know, you want some action. You want something happening, right? And as I said before, what if it's, I think we need to reduce this medicine. I think we need to stop this. I think you're over medicated right now, and this is not necessary. This is going to make you feel better. It's looking at that and not thinking you have to add something on, that every problem is a new problem, that instead deprescribing is part of the everyday thought process. It's not just prescribing, it's the other side. Can I deprescribe something? Is something causing this? So that is part of what I see when we're going for our regular health visits. So we're feeling fine, but we're going for a physical, say, I would love to see electronic records to have continue or deprescribe next to the medicines. You have a conversation about each medicine. Are we going to continue this, or are we deprescribing it? Every single year, that should be happening. So like that's what I am passionate about. That's what I would love to see happen. I want to see that not only at the doctor's office, but when I'm at the hospital and my students are on with me too, and hopefully they're smiling, because we do this when we're there, is, you know, what medicines can we get rid of? What don't they need anymore? What medicines brought them here? You know, kind of thing. And we're always thinking about that, going, what was misused, maybe what over the counter interacted that people are taking. Like, there's so many scenarios I can I could go on and on and on about all the different scenarios. I'm sure you could too, Debbie. Over 25 years of experience, there's a lot of stories. There's a lot of things that have happened. And so I've connected with people for years and years and years and tried to work with them on deprescribing. I just want it to be more of a thought process. I don't want people to say, oh, I have my meds checked at my doctor's office. Like, they might really go through every one, but do they all do that? Do you really think that you just going over your meds prior to your doctor coming into the room is a review? It's a checklist. It really is just, we want to match up your records with what we think, with that, what you're taking is what we think you're taking. So I want those conversations to go a step further.
Yeah, definitely. Being your own self-advocate and even not being embarrassed. I mean, like you mentioned, I took care of a lot of patients. I have. There's sometimes when finances becomes an issue, and not to be embarrassed to share with your doctor that you can't afford a medication. And that you've been taking, instead of a medication that you're supposed to take maybe twice a day, you've been taking it every other day just to kind of make it last. Don't be embarrassed. Don't be ashamed. If you cannot get to your pharmacist, you don't have any support systems, you can't afford it, or if you just don't understand the medications, why you're taking them for such a long time, ask questions.
Right.
Come away from your appointments feeling that you were heard and seen. So can you mention your book one more time? Because I know it's going to be released soon, and we are almost at the top of the hour, because I want to make sure that people get that name, the book.
Thanks. So it's called Med Strong. So similar to what this program is, right? Aging Strong. Med Strong, Shed Your Meds for a Better, Healthier You. And like I say, it's not shedding all of them. It's, focusing in and optimizing the medicines. And it's all about, aging well through deprescribing. That's what we're trying for. So it should be out in towards the end of the summer of this year. And also, if you just want general information, a lot of these templates that I shared with you in the slides, those are on my website, donnabartlett.com. So you can go in there, click on the templates, and that information is there.
Oh, wow. That's great. Thank you so much. That's a great bonus. Thank you.
Sure. Right, my pleasure.
Donna, thank you so much for being here. I learned so much, and I always do whenever I hear you present. That's why I had you come on. So thank you so much. And again, thank you to the Quincy Public Library and QATV for having me, helping me do my outreach program in this way. So I want to invite people to come back again in 2 weeks. I will have somebody from the Brain Injury Association of Massachusetts. They'll talk about brain injury, the latest information about brain injury, and also resources. So I invite you back on February 22nd. We will have Justine Cody from the Brain Injury Association of Massachusetts on. So thank you so much again. Remember, deprescribe to optimize, right, Donna?
Yes.
Do it. Just do it. Thank you, everybody. Be well. Bye-bye.
Thank you.